Well, good morning, everybody. It's nice to see everybody got up early to come to the conference this morning. So let's start navigating through the complex world of anesthesia medications for periodic paralysis. Let's see. There we go. I do not have a conflict of interest to declare. However, I do have a disclaimer. And the disclaimer is that as a rare disease, most of the literature available about this disease and anesthesia medication is limited to case reports, professional opinions, surveys, and anecdotes. So I've done my best to compile and review the available information to form what we call the best practice guidelines to help periodic paralysis patients have a safe surgical and anesthetic experience. But please keep in mind that each patient responds differently, or as it says up there, not all patients respond alike. So let's start out by talking about daily medications in anesthesia. Periodic paralysis patients take over-the-counter medications, they take prescription medications, and most of them take supplements. And anesthesia wants to know what medications you're taking so we can avoid any type of reaction between your daily medications and what we use for anesthesia. For example, these are experiences that we have seen with anesthesia medications mixing with your daily medications. Some of them will prolong anesthesia. Some of them hinder the ability for you to heal after surgery. Some of them cause heart damage. Some of them can increase your chance of bleeding. And then some of them have a toxic effect on your organs like your liver, your kidneys, your pancreas. So let's take a look at one example. Let's just take a look at a blood pressure medication. If you look at the bottom, these are the examples of the blood pressure medications. These belong either to the ACE inhibitors or the angiotensin II receptor blockers. Now, when you combine this with sleeping medications, going to sleep for anesthesia, they can cause profound hypotension. What does that mean? It can cause your blood pressure to bottom out. So that's not a good thing to have starting out your surgery, immediately trying to rescue a patient with their blood pressure. But what we have found, if we know that you're taking these medications, we can tell you to stop them a day or two ahead of time, and guess what? There's no problem whatsoever. Probably one of our biggest concerns, though, are supplements. So I got to keep up there, sorry about that. So supplements, I used ephedra just historically to show you a supplement that had devastating effects on patients undergoing anesthesia when we didn't know that they were taking ephedra. Ephedra was used in weight loss medications, but it would cause, right on the table, severe heart damage to patients. I point out garlic, ginseng, and ginkgo biloba, and there are a lot of other supplements that cause you to increase bleeding during surgery. And a lot of times, surgeons have a very difficult time controlling or even stopping the bleeding when patients are on these supplements and having surgery. Kava and valerian are two relaxing medications. Mood relaxers, one of them's treated for, they use for treating insomnia and so forth. The point I want to make about these medications is that they work on a neurotransmitter called GABA. It's an inhibitory neurotransmitter, but the point is going to be, and I'll show you this throughout the presentation, these supplements act on the same receptor that a lot of our anesthesia medications act on. And combining the two of those together can lead to some pretty disastrous results. So the recommendation from the American Society of Anesthesiology and Supplements is to stop all herbal supplements 2 weeks prior to surgery. A lot of facilities will use 1 week. But one of the big concerns that I have is that herbs and supplements are poorly studied for the general population and much less studied for our population, the periodic paralysis population. And another big problem we run into with supplements is that the bottle label may not accurately reflect what's in the medication because contaminants are common for this group of medications. So the take-home point here is review all medications and supplements with your surgeon and anesthesia provider prior to surgery. Then with your doctor, your periodic paralysis doctor, your primary care doctor, surgeon, and anesthesia provider, work out a program that accounts for your disease maintenance as well as your anesthetic safety. Let's talk about relaxation and sedation. And yesterday we had this great presentation on different ways to relax and so forth. But when you come for anesthesia, we're throwing that out the door. We like drugs. And our favorite class of drugs to use for this are called benzodiazepines, which work well for all forms of periodic paralysis. Versed, Valium, and Ativan are the three main ones. But what I want to point out to you with this slide here, if you look at the second block in, these bind to GABA. Now wait a minute, where have we heard of GABA before? Oh, that's right, under supplements. Those two supplements, valerian and kava, also bind to GABA. So now you're going to use an anesthetic medication that binds to the same receptor. Can produce some very concerning results. So my thoughts on the relaxing medicine and so forth, your take-home point from anesthesia is beware of respiratory depression. And I'm not so much worried about adults, but especially if you have children undergoing anesthesia, that has been a big concern. So just remember, if you start with a small dose and let them increase as needed, is a whole lot safer than trying to take it away once you've given a big dose and now you've got a complication to work with. So let's talk about a dream of mine. The dream of creating the ideal sleeping medication. The induction medication is another word for it. You know, if I could create the ideal induction medication, I could retire and I would never have to shovel snow again. So what would I want that medication to do? I would want that medication to put you to sleep quickly and you wake up quickly. I'd want it to help you with your pain. I'd want it to prevent nausea and vomiting because I don't like anybody to be sick. I want it friendly to the lungs, and I want your heart and breathing to be stable after I give it to you. So the most common medication we use is called propofol. Now, if we look to the picture on the left, the normal way your body goes to sleep and so forth, you have, once again, GABA. Oh my gosh, it's come back again to talk to us. Gamma-aminobutyric acid. It binds with the GABA receptor R. It opens the channel, lets chloride go through the channel, and as more chloride, the more negative ions that go through there, the more sedate you become, or off to sleep you go. Now, how propofol works is it binds to that GABA, so this is on the right picture, causes that channel to open, but that door now opens and closes very quickly. It opens, closes, open, closes. So each time that door opens, more of the chloride comes in. And that's how propofol works to put a patient to sleep for anesthesia. Now, if we compare that to an ideal agent, the one that I hope to create someday, if you look at propofol, yeah, it's quick to go to sleep, quick to wake up. It helps with nausea and vomiting. It's nice to the lungs. However, it does not provide any pain relief. And it can intensify cardiac or respiratory depression, especially when you have other health conditions or medications added to it. There's a study done by Roger Rayan and Hannah back in 2020 where they surveyed 109 patients with periodic paralysis or non-dystrophic myotonia. And one of the take-home points for me was of 109 patients here, only one patient had a problem with propofol with their general anesthetic. And that goes along with the available literature that shows that propofol appears to be a safe option for patients with periodic paralysis. However, yeah, there is a however here, many patients have comorbid conditions, other health issues like maybe a mitochondrial dysfunction or a lipid myopathy, where propofol may cause profound weakness. So my next question would be what are other options? Well, what about ketamine? Ketamine is a selective antagonist of the N-methyl deaspartate, or NMDA, brain receptors. It works by causing a dissociative effect, like a dreaming effect. For example, one patient woke up from surgery, and his dream during surgery was that the Cleveland Browns won the Super Bowl. So there's no accounting for what dream you might have. Ketamine works different than propofol. In your central nervous system, you have an excitatory brain neurotransmitter called glutamate. If you look on the picture on the left there, when glutamate binds with the NMDA receptor, it causes the channel gate to open and the calcium and sodium to enter through and transmit on to the next ion signal, to the next nerve. Now, when you take ketamine and give that to a patient, it binds in place of the glutamate, and it takes and closes that gate, so it blocks out the calcium and sodium. And once it blocks that out, boom, the patient goes off to sleep. So how does this compare to our ideal agent? Well, it is great to go to sleep and great to wake up. Works very quickly, and it does help a little bit with pain. In my opinion, not clinically, not significantly enough to say, hey, this is what I would use for pain medicine, but it does help a little bit with pain. And it can reverse some asthmatic issues that a patient might have. But on the other hand, one of our biggest concerns was that it causes nausea and vomiting, and it increases a patient's heart rate. So when I give this to a patient, all of a sudden their heart rate's going to surge. And when their heart rate goes up, their cardiac output increases. And when their cardiac output increases, their blood pressure increases. So this is not a very good medication to use for people with heart disease or strokes. And another issue, you got to be careful of any head injuries or brain issues and so forth, because it increases intracranial pressures, which is the pressure that's inside a patient's head. So what's our third option? Our third option is etomidate. Etomidate works similar to propofol. Oh, you see the GABA there once again? My, that's been a recurring theme this morning. So how etomidate works is it binds with GABA, just like the propofol did. But remember, the propofol worked by opening and closing the door. Open, close, open, close, open, close. Okay, so very quickly, more frequently. The etomidate works by opening the door and keeping it open, so it lets the chloride in that way. So it's a little different mechanism of action. Now, etomidate is a synthetic carboxylated imidazole derivative that has hypnotic properties, and it works very well. It is great for patients to preserve their heart rate and blood pressure and their respiratory status. However, it does have some concerning side effects. One of them is when you give a sleeping dose of etomidate, it can cause myoclonic reaction. And what a myoclonic reaction is a sudden involuntary twitching or jerking of a patient's muscles. And to me, if you have a neuromuscular disease already, you have issues there, I don't think this would be the best way to start your anesthetic experience. A second thing is it can cause adrenal suppression. And the treatment for adrenal suppression is using steroids. And steroids are probably not the most friendly to most of our forms of periodic paralysis. So as compared to the ideal agent, yes, quick to sleep, quick to wake up. It's great for preserving the heart and breathing, but it's known for the myoclonius. It does cause patients to get sick, and it's also known for the adrenal suppression. So what are my take-home points for sleeping medications for anesthesia? I think propofol is the most ideal induction sedation medication that we have today. Most periodic paralysis, non-dystrophic myotonia patients with the case reports use propofol without any incidents, barring the comorbid conditions. Ketamine would be probably my second alternative, but that's dependent on whether how their heart looks and any issues like strokes and things with the brain. Etomidate would be the last on my list because I'm concerned about the adrenal suppression and I'm concerned about myoclonic muscle injury. So I'd reserve this for patients that have severe cardiomyopathy. What does that mean? Those that have severe heart failure. That's where I would reserve using this medication for, because these other complications to me appear concerning. So anesthesia gases, the big mystery. Roger Rayan and Hannah in 2020 reported that around 1 out of 3 people that they surveyed said they had problems with general anesthesia. But one of the things that they also point out in this survey is beware that because this is self-reporting, there is no information on how well the patient's triggers were controlled. And so whenever you're looking at a piece of literature and so forth, you have to look at it with a critical eye to make sure that they account for all the variables that can alter the outcome of the results that they're trying to look for. Now, for anesthesia gases, surprise, surprise, the exact mechanism of how they work, we don't know, but we know they do. For a periodic paralysis standpoint, I'm going to suggest that the anesthetic gases that are used for this patient population be sevoflurane, isoflurane, and nitrous oxide, because these appear to be the safest ones with this disease population. I would avoid the rest of them. Now, halothane and enthrane's out, halothane's on its way out, and you still have desflurane. I would still avoid desflurane with our patient population. So just like the sleeping medications did not provide pain relief for a patient, anesthesia gases do not provide pain relief for a patient either. So let's talk about muscle relaxants. We're talking about muscle relaxants. We're not talking about the nice tablets you get at home to take and help your sore muscles, your pulled muscles, things like that. The medications that we use in anesthesia for muscle relaxants actually cause muscle paralysis. And they do this by blocking nerve impulses to the muscles. Muscle relaxants are necessary for us in surgery and anesthesia because that's how we're able to place breathing tubes to protect the patient so they breathe. We believe that breathing is good. And they also help the surgeon because it creates an ideal surgical field, so it's easier for them to complete the surgery without complications. Once again, sleeping medications for anesthesia, anesthesia gases, and now muscle relaxants, point number 3 here, do not relieve pain. None of these are going to help you with your pain. There's 2 types of muscle relaxants that are used in anesthesia. The first one everybody in this room should know about. This is called succinylcholine. It is a depolarizing muscle relaxant. So if you look at the picture here on the right, when the succinylcholine is given to a patient, it binds to the motor end plate and blocks out the acetylcholine. And when it does that, it opens the channel and allows sodium to go through. And it keeps that door open so that sodium continues to go through. So what happens is the patient will have one contraction, and then the additional sodium will desensitize the neurons, and they'll take and cause the muscle to relax. Now, we like this medication in anesthesia for 2 reasons. One, if we need to establish an emergency airway, get a breathing tube in somebody right now, this acts very quickly and allows us to place the breathing tube very quickly. Number 2, we like it if we have a patient with a difficult airway, because not all patients are made alike. In some people, it's harder to place a breathing tube than others. And this allows quick onset that we can go ahead and try to get it in, but if we can't get it in an appropriate time, it wears off and the patient will start breathing on their own. So it's very useful for anesthesia. However, succinylcholine should not be used for periodic paralysis or non-dystrophic myotonic patients. Succinylcholine is contraindicated in all forms for periodic paralysis because it can precipitate myotonia, which is a stiffness or weakness that can last for days. It's a different type of stiffness or weakness that you have with the disease process. It can cause masseter spasms. Masseters, that's jaw spasms. And you're like, well, geez, why would that be a problem? Well, it's difficult because once you have the jaw spasming, anesthesia, it's virtually impossible for us to place a breathing tube. And for a patient, it's virtually impossible to breathe. You have an airway obstruction when you have a masseter spasm. So it's very, very dangerous all the way across the board. And it can also cause hyperkalemia, which obviously is dangerous for hyperkalemic periodic paralysis patients and some of the Anderson-Tawil syndrome patients. And succinylcholine has been known to cause death for periodic paralysis patients. So we stay away from succinylcholine. And I'm going to take and digress here for a minute because I was shocked. I guess last night I met some people, or a whole group of people and so forth. And I want to encourage everyone here in this room that's affected with periodic paralysis to have an emergency alert ID band that you wear all the time. And the reason why is because if you're in an accident and so forth, they rush you to the hospital and they're going to take and work on you and they got to put a breathing tube in or take you to surgery or whatever. In those emergency cases, the number one go-to muscle relaxant is succinylcholine. And if you don't have something that tells them, it can be on your wrist, it can be a chain, whatever, EMS, the hospital, they're all trained to look for these things. But if you don't provide them with that information, that's the first thing you're going to get. And so your recovery already is hindered right from the get-go. So it's very important to have an emergency identification bracelet to let people know I cannot have succinylcholine. So what do we use for muscle relaxants for periodic paralysis patients? Well, we use what's called non-depolarizing muscle relaxants. They're a competitive antagonist. And what does that mean? An competitive antagonist means it actively pushes or blocks the acetylcholine out of the receptors there. So if you see the MR, that's the muscle relaxant there. It actively blocks out the acetylcholine, closes that sodium channel, and when no more sodium can pass through there, your muscles relax. So an example, this is probably the most common example, would be the rocuronium. Now, some thoughts about the non-depolarizing muscle relaxants. Repeated doses are not a problem for periodic paralysis patients. But our goal in anesthesia is to use the shortest acting muscle relaxant that we can. So our goal, and if you look at the literature, they say give only 10 to 20% of the muscle relaxant that we would give a normal patient. Our big concern is residual paralysis because it's very difficult to distinguish residual paralysis from a periodic paralysis attack after surgery when the patient's waking up. So what we like to do, we like to be in command of things and so forth. So we like to use things that we want to use something that will reverse that muscle relaxant. So what we have, once again, incomplete reversal of muscle relaxant is a major concern for all surgery patients, but it's even more concerning when you have a neuromuscular disease because breathing as the first thing is important, and number two, we want to make sure we're treating the right thing. For years, we've used what's called a cholinergic medication, neostigmine is what it's called, to reverse the paralysis. And when we give this to reverse the paralysis, we have to give another medicine to reverse the cardiac effects that this medication causes. And what we have found, though, that this medication is a big problem for periodic paralysis and non-dystrophic myotonia patients. In fact, the only ones that have any recommendations that we use this for periodic paralysis is we can use it on a limited basis for some hypokalemic periodic paralysis patients. And the reason why is because with the other forms of periodic paralysis patients, it can cause masseter spasms. That's the jaw spasms we talked about. Can't put a breathing tube in, patient can't breathe, that's not a good thing. And the other thing is respiratory muscle stiffness. Now, when you breathe in and out, your rib cage moves in and out. And you need your rib cage moving in and out for you to take a good breath. And patients that experience this respiratory muscle stiffness are in respiratory distress because they cannot breathe in and out. And so that can be very scary and a very serious complication from an anesthetic perspective. However, the cholinergic muscle relaxants reversals are not a good choice for periodic paralysis patients or non-dystrophic myotonia patients. But the good news is we have a newer medication called Sugammadex. And this is a newer non-depolarizing muscle relaxant medication. And I tell you, I've stopped for a moment, point out my artwork. I really liked the mechanical robot there because that's representing my Sugammadex molecule. And what it's done is just going in there, it's just ripping that muscle relaxant right out of the receptor so the sodium can go back through and the muscles can regain their function. So research with Sugammadex, one of the best studies I've seen that I've really enjoyed reading was research done by Gurunathan, Kunjo, and Stanton back in 2019. And what they did was reviewed 43 articles where Sugammadex was used in adult patients with neuromuscular or neurological diseases. And what they found is that Sugammadex has been used successfully with conditions like myotonic dystrophy, myasthenia gravis, Becker's myotonia, and congenita, and Duchenne's muscular dystrophy. Merck, who makes it, and of course wants us to know that there's even more benefits for it, but there's less pulmonary complications with using this medication as well, which is another good thing for our patient population. So my take-home point is that Sugammadex appears to be a viable option for periodic paralysis and non-dystrophic myotonia surgical patients. But anesthesia needs to keep a very close eye when using this medication with this patient population to counter any possible side effects that may occur. Pain control. With general anesthesia, pain control, as you are now understanding, does not come from anesthesia gases, sleeping medicine, and muscle relaxant. We actually have to give pain medicine for control. Opioids, the acetaminophen, NSAIDs are our go-to medications for this case. Regional anesthesia, which works the best for periodic paralysis patients, takes away all the pain. So it's just putting numbing medicines on the nerve that numbs it up, and so your body doesn't respond to the pain at all. And local anesthetics work the same way. We'll talk about local anesthetics here in just a minute. Take-home point, though, with opioids. Whenever you're getting opioids, and once again, especially the pediatric population, and many of you probably have already experienced this, is you got to be very careful with respiratory depression. So start with a small dose, work the way up is much better. And also with our patient population, we've seen some muscle rigidity as a result of some of the pain medications. So starting with a smaller dose gives time to identify issues and correct issues before you have a major incident. Acetaminophen is Tylenol. NSAIDs, an example, would be ibuprofen. My thoughts with this is just to tell you that Tylenol works great for pain and for fevers, whereas the NSAIDs, the ibuprofen, works great for pain, fever, and inflammation. Now, before you decide, oh, well, yeah, I get inflammation with surgery, so after surgery I'm going to make sure I load up on the ibuprofen, remember it also inhibits platelet aggregation, which can cause bleeding, which could cause a post-op complication for you. So always follow your surgeon's instructions with the use of ibuprofen post-operatively. I don't like that slide. I came up with this instead. Yeah, I hope I didn't hurt its feelings. Let's take a minute and explain. People hear me say regional anesthesia is the best type of anesthesia for periodic paralysis, non-dystrophic myotonia patients. And so let me take a minute and show you why I believe this. If you look at the graph there, you'll see the vertical axis says pain level. And if you remember, if you have surgery, they're always asking you what's your pain level. 0, no pain, 10, worst pain in your life. So that's representing a patient's pain level. The bottom, the horizontal axis there is showing time. And the time that I put out is induction. That means when you go to sleep for anesthesia. The next one's incision, when the surgeon starts and actually does the incision. And emergence means when you're waking up. Now, if you see the red line that's grafted there, this is here for theory only. This is not how we practice anesthesia. But if you just use your sleeping medication, anesthesia gas, and muscle relaxant, and that's all you give the patient to go, and they're asleep for anesthesia. Now they're sound asleep. The surgeon does the incision immediately. There's no pain relief. The pain goes up to 10 out of 10. It's off the scale, worst pain the patient's ever had in their life, but they don't know it because they're completely asleep. This is not how we practice, but it's to help you understand. The next one is if we're going to put someone to sleep with just general anesthesia, we need pain medications to control the pain. And so if you look at the purple one, you see no pain at induction, no pain at incision. He does the incision. All of a sudden, the pain goes up between 5 to 6. You can never safely give enough pain medicine to block all that pain for a patient when they're having incision for surgery. So yes, a patient's going to have that pain. It's going up to 5 or 6. We'll give more pain medicine. So when they wake up, their pain's down to maybe a 2 or a 3, which is more comfortable for waking up with. Now, if I would take and do a regional anesthetic on a patient. So I would do a spinal, which would numb the patient from the belly button down, or an epidural with the same results, or a nerve block. A nerve block, for example, if you're going to have shoulder surgery, I can put numbing medicine up here by your collarbone. There's 3 branches to block. I can put numbing medicine there, block those 3 branches, and guess what? You won't feel anything. So you go to sleep. You we start out the green now, go to sleep for anesthesia, because we're not going to keep you awake for the surgery, so off to sleep you go. Don't need as much anesthesia. Surgeon does the incision. If you notice the green line, the pain remains at a 0 through the entire procedure. Now, my point is this. If you see that purple graph line there, and you see how that pain surges up to a 5 or 6, and then we give more pain medicine to bring it down, when that patient's feeling that pain level's going up, that causes a sympathetic stimulation in the body. And that sympathetic stimulation is what can cause a patient to have an attack right then and there during surgery. If you have a regional anesthetic, you don't have that surge, you don't have that sympathetic surge, and everything stays nice and level through the surgery, and you've eliminated one possibility of having an attack while you're under anesthesia for surgery. This is why I like the regional anesthesia for periodic paralysis patients. And I will tell you, if you're going to do anesthesia on me for any of these surgeries, I want the regional first. Let's talk a little bit about local anesthetics. There's esters, amides. Nobody cares about that. We use the amides because there's a lot less side effects with them. Lidocaine, bupivacaine, ropivacaine are the main ones. And in my practice, we still use some bupivacaine. It does have uses for us. Don't care about that, but what I do care about is that, so for local anesthesia, our special notes for periodic paralysis patients are we don't want to use bupivacaine for Anderson-Tawil patients because it's cardiotoxic. So any medication that gets absorbed into the bloodstream will affect the heart. And these types of patients already have heart issues, and we don't want to complicate that anymore. You don't want to mix these local anesthetics with epinephrine, especially for hypokalemic periodic paralysis patients, because that can trigger a periodic paralysis attack. Now, some hypokalemic periodic paralysis patients note that lidocaine as a local anesthetic is not an effective numbing agent. And there is a group of hypokalemic periodic paralysis patients that this applies to. And the rest of them, it still works. So we'll talk about that in a few minutes. But what I do want to drive home is don't put lidocaine as a allergy for you just because numbing medicine doesn't work. Because it's been shown time and time again when these patients, the hypokalemic periodic paralysis patients, end up in a ventricular dysrhythmia, which can be life-threatening, lidocaine still works. So lidocaine as an IV medication will still work even though it doesn't work for you as a numbing medication, and that's because there's two different mechanisms of actions being used here. How many times have you been to a doctor, medical person and so forth, and you're trying to explain to them, and I'll use the example here, hey, lidocaine doesn't work for me as a local anesthetic and so forth, and by the time they get done with you, you're asking yourself, am I nuts? Has that happened to anybody here? Only one person. Oh, okay, there's a couple more. Okay, yeah. I thought this would be a common theme for everybody here. Getting doctors to listen and understand the disease process. So I took a look at lidocaine, and my question was, why does lidocaine not work for some of the hypokalemic periodic paralysis patients, yet work with some of the other ones? And what I found out is resistance to local anesthetic does not just apply to some of our hypokalemic periodic paralysis patients. A literature review called the a study of resistance to local anesthetics was published last year in the British Journal of Anesthesia. None of these are examples of periodic paralysis patients because I couldn't find a study involving periodic paralysis patients. But what I did figure out is that our patient group is not alone. For example, I found this very intriguing. This is something we've been working with in anesthesia. There was a study done where 3 family members were resistant to local anesthetic, but they also had altered sensation to temperature and touch. And they had a mutation at the SCN5A. The other family members, outside these 3, did not have any problems with sensation and touch and did not have this genetic mutation and didn't have any problem with local anesthetics. So short story is that they tried to figure out what the mechanism of action is that would cause these patients to be resistant to local anesthetic. What they concluded is that they think the genetic mutation might have some meaning here, but they have no clue as to why it's happening. Some of the patients here I know also have Ehlers-Danlos syndrome. That patient population also have problems with resistance to local anesthetic. And the theory that goes with this is it's a connective tissue disease, and this disease affects the connective tissue and it alters how the local anesthetic is dispersed in the tissues, and that's maybe why it doesn't work well with this disease population. Other studies have involved patients, the genetic patients for patients with red hair. Opioid patients have resistance to local anesthetics, so they're trying to figure out what the interaction is there. They even have done a study of scorpion stings. If you've been stung by a scorpion, the venom has the same binding site as where the local anesthetics go. So the question is, could scorpion stings cause an alteration or damage to that site that affects the binding of local anesthetics? But my take-home thought is more research is needed to determine why hypokalemic periodic paralysis patients are resistant to lidocaine as a local anesthetic. And at this point, I have not been able to find anything that can direct us to answer this question. The next thing are the antiemetics. This is medications to keep you from getting sick. The 3 major ones, which would be the Zofran, the Reglan, and the Phenergan, so all of those cause a prolonged QT segment on a patient's EKG. So if you look at the EKG, on the far right in the middle is the QT interval. And what happens with these, when you take these antiemetics, it can cause that to become prolonged. And so where our concern is patients with Anderson-Tawil syndrome and so forth, they tend to already have a prolonged QT. And the problem with a prolonged QT interval is that it causes life-threatening heart dysrhythmias. So care must be taken to avoid this type of medication that would further increase the QT interval. So we want to be very cautious about our choices for antiemetics for this patient population. So I'm going to be reaching my conclusion here shortly. I wanted to talk for a little bit about just something that disturbed me on social media. A person with periodic paralysis posted on social media that she had a serious discussion with anesthesia and had to educate anesthesia that propofol triggers malignant hyperthermia with periodic paralysis patients. That statement alone doesn't bother me, but then everybody else chimed in and says, oh yeah, great job, wonderful, wonderful, but that is misinformation. That is not true. Propofol is what we use to avoid malignant hyperthermia. Does not cause it. What does trigger it though is succinylcholine in all the anesthesia gases except for nitrous oxide. So my take-home message with that is just be careful where you get your information from. Be careful what information you share, and be careful with whom you share your information. The Periodic Paralysis Association has a program called Ask the Expert. It's a great source for current and professional information, for questions about periodic paralysis, and all the information there is kept confidential. So if you also go to the periodic paralysis website, you're also going to see quick reference guides for hypokalemic periodic paralysis patients, adults, and pediatric. So if you're going to have surgery and you have hypokalemic periodic paralysis, go to the website, and there's different areas where you can find them. You can find them on other areas as well, but they're published. That's their home publication is there. But take and download that, print it off, and hand that to your anesthesia provider. Gives them detailed instructions of what to do and not to do for you with hypokalemic periodic paralysis. Now, if you have the other forms of periodic paralysis, please realize those guidelines are in the works. And I apologize, it takes a long time to put these together with the research, the peer review, and the just pulling through all that information, getting it in a succinct, readable fashion. Another thing I want to share with you is the University of Cincinnati, the nurse anesthesia doctoral program last week has started a project, a research project on periodic paralysis. So this will be an educational research project in which when they're done, they're going to be sharing this information with anesthesia throughout the state of Ohio. In particular, the state meeting, which will be next March, and we're hoping to get booked into the national meeting in a year. Last thing that I'll talk about is that I'm going to conduct my own research program. I like your cooperation with it. We're going to take and put together a survey of our own for anesthesia concerns and so forth that we're going to take and allow each of you to take and be a part of. So that way, in the future, we can figure out, hey, where are our real concerns with anesthesia and what can we do to help change that for our patient population. So that way we're not relying on studies done outside. Let's do our own and figure out what can we do to help. Ladies and gentlemen, thank you very much. I wish you a great day.
If you would like to know more about periodic paralysis, visit periodicparalysis.org. And if you enjoyed this video and want more, hit that like button, subscribe to our channel, and hit that bell so you don't miss any future videos. It really does help spread the word. You can view other videos about periodic paralysis by clicking the thumbnails to the right. If you have questions, just leave a comment below or reach out to us on social media. We'd love to hear from you.